I'd like to welcome all of you to the Many Faces of Colon Cancer. My name is Margaret Stauffer, and I'm going to be the MC this evening. We are so pleased to have a great panel of physicians and dietitian who are going to present a lot of information. Our next speaker is Dr. Jewel Joel. He's a medical oncologist and colon cancer specialist with Diablo Valley Oncology. And if you find yourself wanting to ask Dr. Joel a question, please select the green card from your program. Thank you. Dr. Joel.
Thank you very much. I appreciate the privilege to be here and talk about colon cancer, treatments of colon cancer. So what I'll do is, it's very difficult to cover everything in 20 minutes, but I'll give you a brief overview of how colon cancer is treated and some of the advances we have coming up in this field. So some of the slides may be redundant based on what Dr. Zamani has talked already. Colorectal cancer is very common. It's the second most cancer, as we just talked about. And the number of people dying from colorectal cancer has declined over the past 20 years thanks to screening done by gastroenterologists, a greater interest in prevention, diagnosis, and also treatments that have become much more advanced. We will talk about some of these treatments in a moment. And screening or removing polyps early is the best way. And patients usually ask me, about my profession and seeing patients who are ill, but quite honestly, it's a joy and privilege to help patients in different stages of cancer. And it's really a pleasure to find patients whose cancer gets diagnosed early, because those patients are highly curable with surgery, a combination of surgery, and sometimes patients need chemotherapy afterwards, which we will talk about in a minute. Signs and symptoms. Most people initially, when they are diagnosed with colon cancer, do not have any symptoms. That's where prevention and colonoscopy is very important, as Dr. Zamani alluded to. Symptoms, some patients who have symptoms could include a change in bowel movements, blood in the stool. That could be a warning sign, but as I mentioned, colon cancer may not present with any signs or symptoms whatsoever. Occasionally people have abdominal discomfort, weight loss, and by the time people have symptoms, generally speaking, the cancer seems to be much more advanced, and that's why screening is so important. So what are some of the tests that are used? Colonoscopy is a very important method of detecting cancer, as has been mentioned recently. There are also blood tests and imaging studies and surgery, which Dr. Kim will be talking about, but all these tests are done after a patient has had a colonoscopy and a biopsy has been performed and a cancer has been diagnosed. Then we order some additional tests to figure out if the cancer has spread anywhere else, which is called staging. So staging means trying to figure out if the cancer has spread to any other parts of the body. In addition to checking routine blood tests, we also do some additional testing on the tumor, which can help us figure out what's the best treatment to give. For example, we do DNA analysis on the tumor, checking for a mutation called KRAS. And this mutation can help us determine whether patients can receive a type of medication called cetuximab or Erbitux. Oncotype DX colon cancer analysis is another test which is now becoming readily available, and it helps us figure out which patients need chemotherapy, especially in patients who have stage 2 cancer, which I'll talk about in a minute. And also, with modern techniques and modern DNA testing, we can also figure out from the tumor specimen after the biopsy is performed if certain patients have a family or familial factor, such as a test called microsatellite instability, which screens for Lynch syndrome, which is a genetic condition that can be inherited that increases the risk for colorectal cancer. So when the patient has had a screening colonoscopy, patients are diagnosed with colon cancer. The next thing we do is we do a CT scan, PET scan, among various tests we do to do what's called staging. Staging means trying to figure out if patients have stage 1, 2, 3, or 4. And that really determines what treatment we give patients. So hopefully, if cancer is found, we hope it's found in stage 1, 2, and 3, because those 3 stages are curable, and they're treated differently, which I'll talk about in a minute. Stage 4 means patient's cancer has metastasized or spread beyond the colon into surrounding tissues or different organs in the body. And some patients with stage 4 are still potentially curable, and that's becoming more and more important, and I'll talk about which subset of patients those are. So we look at three different things when we're looking for stage: tumor size, or the depth of the tumor, rather the T stage. N means nodes, has the cancer spread to the lymph nodes. And M is metastasis, has the cancer spread to any part of the body. And that's detected by a CT scan or a PET scan. So all this information is obtained after a patient has been through surgery and after the patient's had some imaging studies. After that's done, patients usually come see me to discuss what the next step should be. This is an example of how we determine the T stage. As you can see, as a tumor invades deeper and deeper into the wall of the colon, the T stage, or the T part, actually gets higher and higher. There are four stages to T1, 2, 3, and 4. Again, what determines the T stage is the depth of the tumor in the wall of the colon. And this is determined by the pathologist after patient has undergone surgery. And in addition to this, lymph nodes are examined at the same time to see if lymph nodes are involved. And we hope patients have at least 12 lymph nodes or more in the specimen, and that kind of gives us confidence, and we can determine staging more accurately. Once patients are diagnosed, they've been through the staging process. It's very important to have a team of doctors and team of social workers and healthcare workers. Some of them are listed on this slide. Treatment of colon cancer is a multidisciplinary effort. It requires assistance of a gastroenterologist like Dr. Zamani to screen and find colon cancer, somebody like me to discuss chemotherapy if that's necessary, a radiation oncologist for certain types of cancer, especially in the rectum. Those cancers are treated with radiation in addition to chemotherapy, and a whole team of other staff like social workers, nutritionists, like TNRIN, patient navigators, pharmacists. It's actually a very big team effort to treat patients with colon cancer. So the goals of treatment, what are the goals? For somebody who has stage 1, 2, or 3 colon cancer, the goal of treatment is to get rid of any microscopic cells that may have spread beyond the colon or the lymph nodes. And for patients with advanced disease, the goal of the treatment is to make patients live longer, make sure they have better quality of life, and for certain stage 4 patients who have stage 4 cancer, it still is potentially curable, and that's still a goal, especially if the disease is limited to the liver. So I'll talk briefly about different types of treatments that are available once somebody's diagnosed with colon cancer. Obviously, surgery is very important, and Dr. Kim will talk about that a little bit more. Chemotherapy, which is what I'll talk about in a minute. And sometimes patients are treated with a combination of chemotherapy and radiation together, or sometimes with just radiation alone. And increasingly, we have a lot of new drugs that are available, which are called biological drugs, which are combined with the chemotherapy to make the effectiveness even more. And certainly, our institution and John Muir are actively participating in clinical trials to figure out a better way of treating cancer. So this is just a brief summary. Again, this is not a detailed a list of different things we do. When cancer is found in very early stage, which is what we hope to find on screening, if it's stage 1 cancer, then patients can be cured with surgery alone. They don't need anything further other than follow-up colonoscopy as recommended by the gastroenterologist. Those patients do not need any further chemotherapy. We hope if cancer is found in stage 1. Stage 2 means the tumor has invaded deeper into the wall of the colon, and usually surgery is followed by chemotherapy for some patients, not all. Many patients with stage 2 cancer can be observed and just be followed by doing blood tests like CEA, getting colonoscopy at routine intervals to catch any cancers if it happens early enough, if it comes back. Stage 3 cancer means the tumor either has invaded deeper into the wall of the colon or it has spread to the lymph nodes. And most of these patients generally require chemotherapy afterwards. And the whole idea behind chemotherapy is to eradicate any microscopic cells that could have spread anywhere else. Again, stage 3 is still highly curable, and up to 70 to 75% of the patients can be cured after surgery and chemotherapy. Stage 4 means the cancer has spread to other parts of the body, including liver, lungs, etc. And these patients are generally treated with chemotherapy and biological agents, which I'll talk about in a moment. And selected patients with cancer limited to the liver potentially can do really well if surgery is done and cancer in the liver is removed after the chemotherapy has been completed. Just to give you an idea, chemotherapy for stage 3 is generally about 6 months. Patients come in, get chemotherapy every other week for a total 12 times, so that takes about 6 months. We're looking into a clinical trial looking at 3 months of chemotherapy instead of 6 to see if 3 months is as good as 6 months. Patients in different, this is a slide that shows different percentages of patients in different stages of cancer. And patients in stage 2 and stage 3 are the ones who are potentially candidates for adjuvant chemotherapy. Adjuvant chemotherapy means the cancer is gone. We're providing adjunctive treatment to get rid of any microscopic deposits of cancer. This is just a brief, a clinical trial which has really changed how we treat patients with chemotherapy for stage 3 cancer and for some patients with stage 2 cancer. For many years, leucovorin and 5-FU. 5-FU was the main treatment for adjuvant treatment for colon cancer. But this was a randomized study done in France where, in addition to the 5-FU and leucovorin, a drug called oxaliplatin was added, and the results were much more superior. So this has become a standard of care for patients who are treated for stage 3 colon cancer and for some patients who are stage 2. For people who are not, this is an aggressive regimen, and if some people are not candidates for oxaliplatin, 5-FU and 5-fluorouracil is a treatment that we can do. Colon cancer treatment is a little different than rectal cancer, even though the rectum is an extension of the colon. But for treatment of the rectal cancer, radiation plays an important role to control cancer in the rectum. And the whole idea behind treatment for rectal cancer is to preserve anal sphincter. And this decision is made in conjunction with the surgeon and the gastroenterologist. But some patients, we cannot save the rectum, and those patients end up with a colostomy. And we will talk about rectal cancer treatment in a minute. For early rectal cancer, the goal of surgery is to provide cure through a procedure called TME, or total mesorectal excision. And this is a surgery performed by Dr. Kim and his colleagues. And it's a very time-consuming surgery. It's done in a very specialized manner. And this is done typically by surgeons highly trained in colorectal surgery, like Dr. Kim. And he'll talk about perhaps that in a moment. As I mentioned before surgery is done, patients generally are treated with combination of chemotherapy and radiation. We shrink the tumor. Once the tumor is shrunk, then the patients go to surgery. And after surgery, they get more chemotherapy afterwards. So as you can see, for rectal cancer, treatment is a little different, where radiation plays an important role. And again, it requires a team of radiation doctors, medical oncologists, surgeons to provide the best outcomes. And the whole idea is to, if we can, to preserve sphincter function so the patients can have a good quality of life. So we talked briefly about treatment of stage 2 and stage 3 cancers with chemotherapy. We talked a little bit about rectal cancer, where we have trimodality treatment with radiation, chemotherapy, and surgery. Well, when patients have advanced disease, stage 4 colon cancer, these are some of the treatments that are available. We use a combination of chemotherapy, and also these days, over the past 5 to 10 years, biological agents such as Avastin and Erbitux are now added to chemotherapy to improve the outcomes. We don't have time to go through all these regimens, and lately, in the last year, 2 additional drugs have become available. One is called Zaltrap and the other is Stivarga, which are given to patients with advanced colorectal cancer. Again, I wish we had more time, but this is a broad overview of what we do to treat patients with metastatic disease. And 2 of the biological agents that we use quite a bit for patients with colorectal cancer, one drug is called bevacizumab, or the Avastin, And the way this drug works is different than chemotherapy. It blocks the formation of new blood vessels that feed cancer, and also a drug called cetuximab, which is also combined with chemotherapy, and also it slows down cancer growth in a different way. And these biological drugs are frequently combined with chemotherapy to improve outcomes. And with testing such as KRAS, which is what I alluded to briefly, we can predict ahead of time who's going to do better or not with these biological agents such as Erbitux. So we don't have to give this drug to somebody who's not going to be able to respond to it. And if it's not going to work, we can save everybody time and effort and toxicity of this treatment by predicting ahead of time who's going to benefit from this treatment. Bevacizumab, again, is a drug that we don't have much time to get into. Again, it's combined with the chemotherapy, and it's approved for treatment in combination with chemotherapy drugs, and generally well tolerated. Just because it's a biological drug and it's not chemo, does not mean it does not have side effects. People getting these drugs can get hypertension, strokes, blood clots, etc., and heart attacks, and we have to be careful when we're using these drugs and choose patients carefully who should be receiving these. Cetuximab is an antibody treatment which targets a protein called EGFR on the surface of the cancer cells, and this particular drug inhibits the function of EGFR and prevents the biological mechanism where the cancer cell divides and stops its growth. And it's synergistic with chemotherapy and radiation, and this drug is also used for other cancers such as head and neck cancers. So we talked briefly about treatment of metastatic disease with chemotherapy and biological agents, but there's a group of patients with metastatic disease who actually can potentially be cured. And these are the patients who have cancer that has spread to the liver. If it has spread to the lungs and other places, it becomes much more challenging. But patients who have disease that has metastasized to the liver potentially can be cured. 50 to 75% of the patients with advanced disease will develop liver metastasis at some point in their life. And 15 to 25% of patients actually have liver metastasis at presentation. And about 20 to 35% of patients will have metastatic disease, confined to the liver. So this is a slide that shows 5-year survival for patients. So as you can see, over the past, since the 1980s to the 1990s, some of these patients actually undergo chemotherapy to shrink the cancer, and then these patients are taken to the operating room and have those spots in the liver removed. And as you can see, at 5 years, 25 to 30% of the patients can still be alive. And an increasing number of patients are actually cured of disease, even if it's metastasized. Clinical trials, we are actively participating in clinical trials through cooperation with, in conjunction with pharmaceutical industry and also universities in this area. And the whole idea is to make the treatment better tolerated for patients. For example, we're participating in a trial where patients with stage 3 cancer, colon cancer, are randomized to either 3 months or 6 months of chemo. 6 months is a standard. We're trying to see if they can get away with 3 months of chemo and spare the toxicity and side effects of chemotherapy. So it's important for us to offer these trials and cutting-edge drugs that we have available to all the patients. So I think I'm running out of time here. Just a few more minutes. So there are a lot of, once we have patients, once they've been diagnosed, they come and see us, there are a lot of different factors that come into play when we decide who should get treatment and who should be just observed. The type and stage of disease is very important, as I mentioned. Stage 2 and stage 3 patients get chemotherapy, but not all stage 2. Also depends on person's overall health. When we meet patients for the first time, we go through their health history and try to see what kind of side effects, what other illnesses they have, and that can help us choose and figure out which chemo regimen or which recipe to choose to treat. It also depends if patients have had treatment in the past, what type of treatment, what side effects they had before. So that goes into the decision-making process. In somebody with severe hypertension or stroke, we avoid some of these biological agents like Avastin because of the potential risk for causing strokes. So it's a complex decision that's made by all the different doctors involved, including their primary care doctor, cardiologist, in conjunction with the surgeon to figure out what the best treatment should be. Once patients are diagnosed, they're treated, especially for stage 2 and stage 3 colon cancer and stage 1. There's a regimen, this is a recommendation that are made by different medical societies in terms of how often these patients should be watched. And many of these patients, after they've gone through treatment, we follow them very carefully. We see them every 3 months, for example, for the first 2 years. We get a blood test called CEA to detect recurrence of colon cancer. It's very important that we get the patients back to the gastroenterologist to get screening at regular intervals because these patients are at higher risk for getting colon cancer. These patients are followed by surgeons to manage some of the late side effects of radiation and chemotherapy. And of course, if cancer comes back, surgeons are always involved in that. And some patients also get imaging studies, not everybody, but certain selected patients also get CT scans at some regular intervals to detect if cancer is coming back or not. So this is my last slide, and I would like to end my presentation here, and please feel free to write down any questions. But again, there's a lot to cover in 15-20 minutes, but that's just kind of a broad overview of what I do and how we make decisions about different stages of cancer and what sort of biological agents and chemotherapy drugs we have at our disposal. Thank you.